Good morning, John Webb in Vancouver here. So first of all, thanks very much to Roxana Marin for asking me this. It's an honor with, I understand, Dr. Cribier and Eberhard Grube, both good friends of mine. So I'm asked to talk a little bit about where we're heading with transcatheter valve implantation. Now, my disclosure, I think, first of all, I just say that TAVR continues to evolve. It's fairly mature technology now, but it still continues to evolve and outcomes continue to improve. You know, we've seen dramatic improvements in terms of mortality. Here we are in British Columbia. On the bottom in the dashed green, you can see a mortality some years ago of 5.6% at 30 days, and you can see now we're down to 0.6% mortality. And this is in patients who are still mostly high risk, not low risk. So 0.6%, 1 in 200 at 30 days, pretty darn good in high, intermediate, low risk mixed cohort. It's hard to argue with these results, low mortality, low stroke rates, and so on. There are new controversies, and just briefly, you know, we still have issues with stroke, and the bottom line, though, is that lower stroke rates are coming along. Most sites are reporting stroke rates of, you know, 1% or that sort of ballpark. There's still very much a controversy about embolic protection. Here's the rate of embolic protection in US sites. You can see there's about 600 sites, and some people routinely use, on the left there, embolic protection, almost all of their patients, and most patients just a few, most sites don't use it at all. We have pretty good evidence that stroke rates are slightly lower with embolic protection in most studies, but typically not significantly so. And it's really difficult to make a convincing, in my view, a case for routine use given the cost and the unclear benefit. But, you know, this is going to be changing over the next few years, and this may still become more routine in time. We'll see. Now, pacemaker rates were a huge issue. And again, this is in British Columbia, looking at multiple hospitals. And you can see that the pacemaker rates were anywhere from 7.9% to 27% some years ago with low implantation with the self-expanding valves, which was very popular at the time. But with time, all of the sites in British Columbia have reduced their pacemaker rates. And now we're all sort of around 5 to 8% on average, regardless of valve type use. So things are really changing in terms of pacemaker rates, which is a big issue, I think, after transcatheter valve implantation. Now, you know, there's new developments in the technique of implantation. Even here's a few images showing using the line of lucency for positioning against the non-coronary cusp and the cusp overlap view, even for a balloon expandable valve, which is kind of what we're doing these days. And with this, I think we can routinely implant a little bit higher, still trying to avoid covering the ostium of the left main coronary artery. And with this, pacemaker rates can fall even further. I think they'll be even less of an issue with time, although persistent left bundle branch block is still a concern, and I think will be more and more something people pay attention to over the long term. We do pay attention to higher gradients with intraannular valves, but I think it's pretty clear that echo is really not necessarily the gold standard. It's something we routinely have to use and we use to follow patients, but it's very accurate and validated for patients with severe aortic stenosis, but not so much for patients who have transcatheter aortic valves, where you tend to get higher gradients with intraannular valves suggested by echo, and higher gradients in general with transcatheter valves as opposed to surgical valves with echo, whereas invasive gradients show that often these are discordant and perhaps a little bit unreliable in terms of post-TAVR follow-up. So, you know, there's a controversy about what to do in patients with small annuli, and you can make a fairly good argument maybe for a supraannular valve in somebody with a very small annulus, but it's really difficult to show that this is convincingly affecting outcomes. There's a lot of controversy. I've just put up here a series of studies that have shown no issues in smaller valves, and the gradient doesn't really correlate, particularly if it's moderate or severe, if it's mild, with late outcomes. So I think this remains very controversial. We have all sorts of new valves coming along. We've got balloon expandable valves of multiple types. We've got self-expanding valves that are supraannular. We have other valves that actually clip on or attach or have some fixation feature that allow special cases to be treated. But, you know, I think with this as well, we have concerns about durability of these valves, and valve implants may become increasingly complex. There's some issues about implanting one type of valve inside another that most people maybe are not aware of. Coronary access has become a big issue for us. You can see with an intra-annular valve, theoretically, you leave the coronaries free, although this is not necessarily the case. If you look at many even sapien implants, you can see that the top cell often actually extends above the coronaries. And it becomes sometimes a question, do you want to involve the coronaries in your TAVI procedure, or do you want to implant high and avoid a pacemaker? And sometimes I think you may want to choose to implant a little bit lower to avoid the coronaries. There you can see a supraannular valve where there's more of an issue, but I think we all know that typically, although cannulation can be an issue, it's not prohibitive. Usually we can cannulate these people. Now here's an example of a patient that did have a problem. This is a high implant of an accurate valve. This patient came in with an acute MI at another hospital. You can see with a non-selective injection, there's a tight LAD stenosis, but they could not cannulate this artery to do an angioplasty. 3 days later, brought back in a TAVI center, and there you can see with non-selective intubation that we're able to wire this and eventually get a guideliner and do a stent in the LAD, but not an ERC procedure in patients who need an acute intervention sometimes. Here's an example of a high implantation of a portico, and well, not even that high, but there you can see that with trying to implant a LAD stent. In fact, the stent's sliding off the balloon because it's gotten caught in the stent strut. So this is an issue, although not a huge game changer for all of our patients. Here's another patient with a high implantation, or with a low sinotubular junction, if you like, and sinus sequestration. Very difficult, if not impossible, to cannulate the coronary. And there you can see a patient with 2 supraannular valves. This was a case that came to my center with an acute MI. I just couldn't cannulate the coronaries at all, and this patient was managed medically. So it can be an issue, particularly in patients who have coronary disease or now who are going to live a long time. Now, we know that we have fabulous results even in low surgical risk patients. And here's the PARTNER 3 trial, which showed a risk of death or disabling stroke 1/3 1 year with TAVI versus surgery, albeit diminishing a little bit by 2 years. And we'll see with later data what happens with that. And similarly with core valve evolute, you can see really dramatically good outcomes in low risk patients with the self-expanding valve. Now, you know, this is a sort of paradigm that's been popularized in that low-risk patients should have surgery and high-risk patients should have TAVR, and in between there is shared decision-making where you take into account patients' preferences and values and so on. But this seems to be applied only to patients being considered for TAVI. It doesn't seem to necessarily be getting applied to patients who are already accepted for surgery. People just go ahead. I think that's going to be increasingly an area of controversy, is making sure that even low-risk patients are validly considered for either procedure. Now, we see issues with bicuspid valves. I think that increasingly we're doing bicuspid valves pretty routinely. We have pretty good data showing fairly equivalent outcomes with bicuspid and tricuspid valves. This is the PARTNER 3 registry that I was involved with, and then the TVT registry, very large number of patients. It is reasonable, I think, to point out, though, that these are selected patients that people thought were good for bicuspid TAVI implantation. So there are patients with bicuspid valves who are clearly not ideal, but it's clearly not a prohibitive risk if a patient is otherwise a good candidate with not too bulky calcium and no severe commissural calcification. Now, TAVR is increasingly moving to younger patients. Here we can see that middle line is TAVR rates increasing while surgical rates continue to fall, albeit not very much. And because there's so much more valve replacement being done, in fact, I think most sites are not finding there's a significant reduction in surgical volumes from, say, 10 to 20 years ago. In fact, they may be increased, albeit with a slight decrease the last couple of years. And median age is falling dramatically. There we are in the blue line on the right, falling age down to 75, but still mostly older patients selectively being done in at least North America. And I think there's increasingly a case for doing TAVR or valve replacement, even in patients who are asymptomatic if they have severe AS, or if they have moderate AS with left ventricular dysfunction. We have several trials that are addressing this. It's certainly not guideline accepted now, but I think it's likely to come that we're going to be more and more eager to treat lower risk patients and younger patients and patients with left ventricular dysfunction and absent symptoms. This is likely where we're headed in the future as the results continue to improve. Durability remains an issue. We have lots of data long-term follow-up or intermediate-term follow-up anyway in transcatheter valves, but still it doesn't extend out as far as surgical valves, and this remains in many people's minds a limitation. Although we're increasingly, as in the notion 8-year follow-up, we're really doing pretty well with TAVR as compared to surgical valves, and it may not be a distinguishing feature. I guess we'll know in a couple of years. But we do know that all tissue valves will fail eventually, and something will have to be done. And patients being done are typically lower and lower risk and younger. And you can see here that if you're down to 70, you may survive 15 years on average, so you may well need a second procedure. And is that going to be surgical removal of these valves, which is sometimes easy, like on the left, but sometimes not so easy if the valve is really adherent, particularly to the supraannular aorta. But we know that we can get really excellent results with valve and valve, or TAVI and TAVI. And here's our recent report from Landes. We were from our center, just showing really pretty good results with that. But there are limitations in terms of coronary obstruction, not just difficult cannulation, but actually obstruction or sequestration. And here's an example of a sapien inside a sapien and an evolute inside an evolute. You can see that the neoskirt, the old leaflets being pinned up, can be quite different. And this can certainly be limitation in terms of redo procedures. Here's a redo evolute, and there you can see there's sequestration potentially of the coronary artery on the left, and then with a little bit of delayed time, you can see that the seal has really closed up the coronary artery in this patient at a coronary obstruction, which is really unfortunate. Now, we can do things like basilica or future maybe picardia and split leaflets, but remember that TAVI valves are typically not commissurally aligned. There's an example with the commissures before TAVI and then after surgery, after TAVI, and they're really not the same. Now, most of the valves now are becoming available with designs or strategies that allow for commissural alignment. Even the sapien, I think you can see fairly soon, can be commissurally aligned fairly reliably, but this is increasingly something that people are paying attention to. But it is important that TAVR is repeatable. Here's one of our first patients to come back 10 years or more following a TAVR, and you can see that this initial valve is below the coronary, and a second valve could be implanted without any obstruction of coronary flow. So this patient was very fortunate. I think really we need to routinely CT model when we redo TAVR, but I would argue that we should be CT modeling with the very, very first procedure, whether it be surgical or transcatheter. And here's an example of a patient at our center that had a Holcomb procedure with antegrade cardioplegia and AVR, and there you can see there's a very small magna ES19 and a new left main stenosis related to anterior cannulation. And you can see that, first of all, angioplasty is very difficult, but the valve really fills the root, and this patient is never going to be able to have a transcatheter valve implantation when this valve fails. Being only 67, that means they're going to have redo surgery perhaps in a decade or so. And perhaps this should have been the point of discussion before the patient had this particular operation. Now we have guidelines. For instance, these are those from the US in 2020. And I just point out here that really, in the US, 65 seems to be somehow the magic number for younger need surgery. Older TAVI is not unreasonable. But the discussion seems to be just that patients need to be screened for suitability for TAVI. But I would argue that increasingly, I think we're going to have to see heart teams examining surgical patients just as closely as they examine TAVI patients, because there is really equipoise there. And I think, even low-risk patients, it shouldn't be just one person making a decision for one therapy and a group for the other therapy. So we're going to see more and more patients having complex procedures as well. This is going to be a big change. Here's a patient having double aortic and mitral valve implantation at the same procedure. This is not going to be a rare thing in future. And here's an example of a patient that's had a evolute core valve for a failed surgical valve, MitraClip for a leaky mitral valve, had an LAD stent, and is now getting left atrial appendage closure. Not going to be a rare kind of approach with patients with multiple transcatheter procedures. I think more and more this is going to become even more sophisticated and more complicated and require more specialized centers to offer these things appropriately. So there's a few thoughts. Thanks very much.